Pain Society, it was part of the pain care film, correct?
That's correct.
So here we see the American Pain Society. What was the role of the American Pain Society with respect to pain as a fifth vital sign?
The American Pain Society coined the term. I think they even trademarked the slogan, pain the fifth vital sign. Working with June Dahl, the American Pain Society was able to convince the Joint Commission to really operationalize that slogan by introducing pain standards. I believe the American Pain Society also was able to influence the VA system to introduce similarly to operationalize pain as the fifth vital sign. And you know, the American Pain Society, the American Academy of Pain Medicine, American Society of Pain Management Nursing, these are professional organizations that serve the interests of their corporate funders. So as professional organizations, when they would weigh in on public policy, they would weigh in as professionals, and that gave them, they were seen as very credible because they were speaking on behalf of professionals.
Do you know whether Johnson & Johnson was on the corporate council for the American Pain Society from 1994 to approximately 2014?
Yes.
Were they?
Yes, they were.
Okay. Now, we see some connectivity to different KOLs. We see June Dahl again, right?
Yes, we do.
And then with the American Pain Society, we see Dr. Russell Portnoy.
Yes.
And if you remember with NPEC, J&J's program, there was another gentleman, Dr. Richard Payne.
That's correct.
Now, he's connected.
Yes.
Now, Charles Argoff, do you know who Charles Argoff is?
I do.
What can you tell the court about him?
Dr. Argoff has been an active key opinion leader, working with multiple defendants in opioid litigation. So he's worked for, I think, for almost every opioid manufacturer, if not every opioid manufacturer. He is co-author of a book with another physician who worked for Endo Pharmaceuticals. I think the book is called Defeat Chronic Pain Now, something to that effect. A book meant for patients that exaggerated the benefits of using opioids, downplayed the risks. I believe he's published papers indicating that the risk of addiction is extremely low with opioids. So he's been a very busy key opinion leader.
So are there any of the others connected here that you want to discuss, or we can go to another group?
We can go to whoever you'd like. I guess there's the American Academy of Pain Medicine, maybe if we wanted to stay on,
Sure.
if we want to look at another professional
Okay.
group.
So the American Academy of Pain Medicine, we see here approximately $573,000 contributed by the defendants, right?
That's correct.
Now, can you tell the court a little bit about the AAPM? And this, you know, I probably can't use that acronym because there's two. The American Academy of Pain Medicine.
Yes. So, well, I would want to point out that the American Pain Society and the American Academy of Pain Medicine, I wouldn't really call them pure front groups. They weren't created by Johnson & Johnson and Purdue. They existed prior to 1996. And in fact, they were not advocating for opioids before 1996. They were advocating for better access to multidisciplinary pain care programs. And as I've mentioned previously, leaders in the United States in the field of pain were generally not advocating for opioids. It was the opposite. They were calling for, they understood that opioids needed to be prescribed cautiously in order to help chronic pain patients. They did change their tune when funding started to come to American Pain Society and American Academy of Pain Medicine to advocate for opioids. That is what they started to do. They issued the consensus statement, which we reviewed, they have consistently taken policy positions and have advocated for more liberal prescribing, even when we had evidence that the patients that they treat and were saying they advocate for were being harmed by an increase in prescribing. They were really continuing to advocate against any kind of intervention that would have resulted in less prescribing.
Okay. Now, let's look at some of the people that are connected to this. Lynn Webster, are you familiar with Lynn Webster?
I am.
Who is that?
Lynn Webster is a key opinion leader. At one point, I think a few years ago, he was president of the American Academy of Pain Medicine. Dr. Webster, I should say, used to have a pain clinic. He got into trouble, or his clinic got into trouble with the DEA. His clinic, I believe, was raided by the DEA in 2010. The DEA had concerns about many deaths in patients who were treated at his clinic. Despite that experience, prior to 2010 and after 2010, has been one of the leading educators in the United States in how to prescribe opioids responsibly or carefully. He is the inventor of what is called the opioid risk tool, which is featured in many educational programs for doctors. It's a tool, it's really like a one-page screening instrument that you give to a patient where they answer questions about their personal or family history of drug or alcohol problems or mental health problems. It's designed to generate a score. And based on the score from the opioid risk tool, a clinician is supposed to stratify the patient to a risk category. So if a patient gets a low score on the opioid risk tool, you stratify them to low risk for addiction, moderate risk, or high risk. If they are low risk, you may monitor them less closely. If they're high risk, you are supposed to monitor them more closely. That tool that he invented was studied and was demonstrated not to work.
So when you first started talking about that, I thought you were going to say the tool and work of Dr. Webster were good things. Were they?
The opioid risk tool, when it became clear that many patients were not doing well on opioids and that there was a public health problem associated with the increase in prescribing, the educational messages that were coming from groups like the American Academy of Pain Medicine, which did tons of CME on opioid prescribing, they did change their messages a bit. So they went from citing, for example, Porter and Jick, and claiming much less than 1% of patients become addicted. They really began to stop saying that. Instead, what they began to focus on was that there are some patients out there, some people who are very high risk. Those are the ones we have to be careful about. And everybody else, it's still extremely low. But let's not forget that a subset of our population may be prone to addiction, and the opioid risk tool was supposedly a tool that would help you identify those risky patients, the few patients we're supposed to be careful with.
So are you aware whether Dr. Webster was ever a paid speaker for Janssen?
Yes.
Was he?
Yes.
Okay. So also with respect to the American Academy of Pain Medicine, are you aware whether the defendant Janssen was on the AAPM corporate council from 1996 to approximately 2013?
Yes, I am aware that they were.
They were?
Yes.
Now, let's look at the Federation of State Medical Boards. Can you tell the court what that is?
Yes, so the Federation of State Medical Boards is another group that I would not characterize as a pure front group. The Federation of State Medical Boards does do some important work. For example, I believe they administer the USMLE, the United States Medical Licensing Exam, where they play a role in the administration of that exam. They also function as the trade association, more or less, for state medical boards across the country, which makes them very influential. I believe in the late 1990s, I think it was probably around 1998, with funding from the Robert Wood Johnson Foundation, which I believe was created with shares of Johnson & Johnson stock and continues to hold many shares of Johnson & Johnson stock. Working with Robert Wood Johnson Foundation, FSMB introduced what was called the Model Guideline on prescribing opioids for chronic pain, a title very similar to that. That model guideline would ultimately be revised. It would be called the model policy. And what the model guideline and the model policy did was was used by state medical boards across the country. Many state medical boards adopted the model policy. And what the policy said was that prescribers, physicians, would not be sanctioned on the basis of their opioid prescribing, the amount, the doses that they were giving out, or the quantities of opioids. That alone should not be used to sanction them. And there was also language in the model policy to suggest that if a prescriber did not use opioids or undertreated pain, that they could be sanctioned. And so the model guideline, the model policy did help change the way states were regulating opioid prescribing. And that model policy, I should point out, along with the APM consensus statement, were packaged into materials that were given to doctors by sales reps and disseminated. Hundreds of thousands of copies were disseminated across the country.
Okay, thank you, Doctor. The book, Responsible Opioid Prescribing, that was authored by Scott Fishman, right?
That's correct.
Okay. Let's go back to the American Academy of Pain Medicine for just 1 second. Just to make sure we've got this in the record right. That is the other organization that put out the 1996 consensus statement, right?
That's correct.
Okay. So let's look, we've talked about the Pain and Policy Studies Group. What about the Joint Commission? I know the court's heard some things about that. Can you explain to the court what the Joint Commission is?
Yes, I would not refer, I would not call the Joint Commission a front group. I believe that the Joint Commission, though, was very much influenced by opioid manufacturers, by Purdue and Johnson & Johnson. The Joint Commission had a financial relationship with both companies. The Joint Commission has tremendous influence on the way that healthcare is delivered in the United States, not just in hospitals, but in outpatient clinics and programs, in healthcare organizations. They are the main accreditation organization of healthcare organizations in the United States. And in order for a healthcare organization to be able to bill Medicare, it's necessary to have an accreditation, either from Joint Commission. I believe there may be another accreditation organization now. And so the Joint Commission, as we've discussed, adopted the pain as the fifth vital, became a major player in the pain as the fifth vital sign campaign. They had been approached by June Dahl and APS, and they began working with Purdue Pharma initially, so that when the Joint Commission was introducing the pain standards, it held major forums in different parts of the country, events where hospital administrators would travel to these events. They'd have to learn these new rules. They would charge, I believe, a hefty admission fee for people to attend these events, to learn about rolling out the pain as the fifth vital sign. And my understanding from the 2003 GAO report on OxyContin and Purdue was that Purdue was paying all of the expenses for these forums, yet the Joint Commission kept the fees. Similarly, the Joint Commission I think it's JRC or JCR, Joint Commission Resources, was like an arm of the Joint Commission where they sold books and materials. If you were a hospital and you now needed to comply with these new rules and you went to Joint Commission Resources to purchase the materials about how you were going to adopt these new policies, the materials you would purchase from Joint Commission were created at the expense of Purdue Pharma, yet the Joint Commission kept the profits on these materials. And the Joint Commission had a similar relationship, I believe, with Johnson & Johnson. Similarly, the Joint Commission Resources developed materials that it sold or disseminated that were sponsored by Johnson & Johnson.
Well, and to that point,
If I just don't want to re-argue what we argued yesterday, just to make sure I'm preserving objections, if I could just have a continuing objection based on the matters we addressed at the end of the day yesterday.
I'll note your continuing objection, Mr. Yoder.
Thank you so much.
Thank you.
Thank you, Your Honor. Mr. Yoder. Based on that sponsoring comment, we see here that our records show J&J or Janssen have put how much money into the Joint Commission?
$2,669,252 total, but for Johnson & Johnson, $545,244.
Now, one of the connecting lines we see here is to a KOL, Nathaniel Katz. You've seen that name before.
Yes.
Is that the same Dr. Katz that was on State's Exhibit 0035, that was on the MSL board, that talked to this defendant about the history of opioids and the problems?
Yes, I believe that's the same Nat Katz.
Okay. Now, let's look at the next one, Dr. Plotty. There's something on here called the American Academy of Pain Management. We'll find out where that one is on here.
They actually changed their name before they went under.
Okay.
I can't touch the board.
But you're not supposed to. The American Academy of Integrative Pain Management used to be the American Academy of Pain Management, correct?
That's correct.
Okay, and we see here Johnson & Johnson contributions in the $265,000 range, right?
That's correct.
And I'm rounding down. We see a tie to somebody named Bob or Robert Twillman.
Yes.
Can you tell the board about Robert Twillman?
Robert Twillman, in recent years, led the American Academy of Pain Management. Bob Twillman was very influential within the Pain Care Forum. The Pain Care Forum, or as I referred to them yesterday, the Opioid Mafia, relied very heavily on Bob Twillman for policy guidance. Bob Twillman and the American Academy of Pain Management, that became the Academy of Integrative Pain Management, aside from providing policy advice and guidance to the Pain Care Forum, they also led many advocacy efforts, both on a federal level and on a state level. So, for example, when the CDC in 2015 was working on guidance for the medical community in prescribing opioids for chronic pain, and it was clear that the CDC's guidance was going to call for more cautious prescribing. The recommendations even were that doctors should avoid going above 90 milligram morphine equivalents, and that doctors should avoid using opioids for more than 7 days for acute pain. It was important guidance that was needed in 2015, still needed today. The American Academy of Pain Management and Bob Twillman and the Pain Care Forum fought very hard to try and block the release of the CDC guideline. And Bob Twillman, for example, lobbied, I believe it's the United States House Energy and Commerce Committee, asking them even to investigate the CDC, suggesting that the development of the guideline was improper. And the other thing that the American Academy of Pain Management did was to, on their website, you could click on a link that I think was called SPAN, State Pain Advocacy Policy. I'm not sure, I can't recall what the acronym stood for. But on that, once you clicked on that link, it would take you to a page that would list every state in the country that might have legislation involving opioids, and it would say, support, don't support. And as you can imagine, if it was legislation that could result in reduced prescribing, or legislation even to prohibit pill mills from operating, you would generally see a position opposing that legislation.
Now, Twillman, is he the same Twillman that we saw Jansen put on the Imagine the Possibilities Pain Coalition, the IPPC, that was with Penny Cowan?
I can't recall that particular document, but if it said Robert Twillman or Bob Twillman,
Your Honor, I'm going to object.
it would be the same person.
If he doesn't even have a memory of the document, again, I object that he's doing what we raised, but it even
Sustained.
goes beyond that, Your Honor.
So, Dr. Clyde, this 2389 is already in evidence, and I believe that my friend, Mr. Ottaway, used one of these IPPC documents when Johnson & Johnson was on the stand. Can we turn to the relevant page? Okay. I don't want you to speculate about something that's already in evidence. So what name do you see here on the roll of J&J's IPPC?
Bob Twillman.
And what is the company?
It says American Academy of Pain Management. That was their name at the time.
Is that the same Bob Twillman you were just talking about?
Yes, that is the same Bob Twillman.
You don't know of another one that was on the pain care form, do you?
No.
Okay, and we see another name. I'm going to come back to her in just a minute. Penny Cowan, you see that name?
Yes, and I see other. I see another familiar name as well, but yes.
Richard Payne?
Yes.
Is that the one you were thinking of?
And another.
Which one?
Jack Henningfield.
Jack Henningfield, Penny Associates?
Yes. So my understanding is that Johnson & Johnson was eager to have Nucynta downscheduled. It wanted Nucynta, which in studies, drug likability studies, was found to be as likable as hydromorphone, Dilaudid, despite the fact that it is a Schedule II opioid, and studies indicated it should be a Schedule II opioid. Johnson & Johnson worked with Penny Associates to try and come up with science to get the drug down schedule. I don't think that effort was ever, well, I know it was not effective because Nucynta is still a Schedule II drug, but they did try, and they did work with Jack Henningfield on that.
Okay. Can you pull to the page that had all the targets on there? Would you know? Okay, we'll come back. Okay, let's go back to the demonstrative here. So we've covered Dr. Twillman. Now, can you tell the court what happened to AIPM? Is it still around?
No, and like I mentioned yesterday, when a front group, and that is a group I would consider to be more or less a pure front group, when front groups get exposed, when the world finds out either through investigative journalists or through Senate investigations, and all of the money that they're getting from drug makers becomes public, and their advocacy for drug makers becomes public. I believe at that point they no longer serve the same, they can't serve the same function as effectively. Drug makers stop giving them money at that, and they can't continue to operate. And so we've seen that happen. We saw that happen with this organization. It's happened recently with the American Pain Society. It happened with the American Pain Foundation. and my understanding is that the U.S. Pain Foundation may be an organization that's going to fall soon. They're having serious financial problems.
Well, so we're going to come back to the financial problems in a second, but you mentioned U.S. Pain Foundation. Tell the court, please, what that is.
That's an organization that existed before the American Pain Foundation went under, but after the American Pain Foundation folded, individuals who had been running the American Pain Foundation, some of them moved over to U.S. Pain Foundation, and U.S. Pain Foundation began taking the American Pain Foundation's place. So, you know, we do see groups fold when they get exposed, but you see others develop or take their place, unfortunately. U.S. Pain Foundation tried to block the release of the CDC guideline as well, and is meant to look like a grassroots organization of pain patients, but really advocates for the drug companies that fund it. It was receiving, we know from an investigation by the Senate Homeland Security Committee that the U.S. Pain Foundation in recent years had been receiving a very large amount of money from an opioid manufacturer called Insys, which made a drug called Subsys. The CEO of that company and other executives were recently criminally convicted for their role marketing the Subsys spray, and they have been a major funder of the U.S. Pain Foundation.
And we see here that Johnson & Johnson or Janssen had funded at least $58,500 from the records we have, right?
That's correct.
Okay, now yesterday we looked at something called the PAINS report on the Institute of Medicine report, right?
Yes.
And can you talk here for the court about what the Center for Practical Bioethics is?
So the Center for Practical Bioethics, the individual who has been running that organization, has been involved in opioid advocacy for many years. In fact, I think even in 2000, 2001, she had a letter to the editor of the New York Times defending Purdue when OxyContin was beginning to get some bad press. This is an organization that has received quite a bit of funding from Purdue Pharma and clearly some funding from Johnson & Johnson as well. As it was becoming clear that the increase in opioid prescribing was resulting in adverse public health consequences, the Center for Practical Bioethics' role was to help opioid manufacturers preserve that status quo by helping them frame all of the harms associated with the increase in prescribing as being limited to abuse, and by promoting the idea that we have an epidemic of pain. The head of this organization was involved in lobbying Congress so that the Affordable Care Act, Obamacare, would include a provision that requiring a panel formed by IOM that would put out a report on pain in America. And that same individual sat on that panel and created PAINS to try and leverage the recommendations from that panel.
And as we saw yesterday, did the defendants try to use the IOM report as a way to market their drug?
Yes, I believe they wanted a report because they saw this as a business opportunity, and then once they got that report, they wanted to make the most of it.
Your Honor,
Okay,
may we
so-
approach this real briefly?
Yes.
Thank you.
proceed, Your Honor?
Yes, you may.
Dr. Clyde, just to back up to your last statement. The testimony that you've given about these KOLs and pain care forum advocacy and front groups, is that based upon your training, background, factual investigation, experience, work in this case, and all of your efforts as both a doctor and a public health investigator over the last 5 to 10 years looking at the front line of the opioid crisis in America and this state?
Yes, and it's based on facts that I was aware of prior to this litigation, as well as some facts that I became aware of through discovery and from my personal experience.
Thank you, sir. Now, you mentioned that several groups have gone out of business or having financial difficulties. You're aware that in 2012, the Senate had a finance investigation into funding of certain groups, correct?
That's correct.
And that included funding provided by Johnson & Johnson and Purdue to the American Pain Foundation, American Academy of Pain Medicine, American Pain Society, the Center for Practical Bioethics, the Wisconsin Pain and Policy Study Group, the Joint Commission, and the Federation of State Medical Boards.
That's correct. And there were also a few individuals who were mentioned by name in the Senate Finance Committee investigation.
And then, are you aware that in 2017, Senator McCaskill conducted a further investigation?
That's correct. And she looked at some different groups. For example, the American Pain Foundation had gone under by that point. So Senator McCaskill's investigation, one of the patient groups they looked at was U.S. Pain Foundation. I was going to be able to point to it, but we flipped it. I don't know where they went.
Well,
but yeah, so some of the groups that Senator McCaskill investigated were different. And I think some of the drug companies that they looked at were different.
so based on your experience, training, investigation, work as a doctor and a public health person, someone who teaches epidemiology, who teaches a class on the opioid epidemic, who has been here before our state opioid commission and who has consulted, taught here in this state and has worked on this case at length. Is it true that Johnson & Johnson, Janssen have connectivity to many KOLs, advocacy groups, and front groups?
Yes, they have been a major player. They have, just like Purdue, have worked with key opinion leaders, front groups, have influenced organizations that might not strictly be front groups. They have had tremendous influence on changing the culture of opioid prescribing in the United States and in doing everything it could to preserve the status quo of aggressive prescribing to ensure that nobody would patch the dam, even though it was clear that we were flooded with opioids.
Now, Dr. Clivey, at times in the past, have you made remarks about Purdue's role in the opioid crisis?
I have.
Prior to the time you got involved in this case and had a chance to see the documents and the testimony which you talked to the board about yesterday,
Yes.
did you know the breadth of Johnson & Johnson and Janssen's involvement in this opioid crisis that we had?
No, I didn't. And like many people, I believed that Purdue Pharma was responsible for the lion's share of the problem. I no longer believe that. I believe, if anything, Johnson & Johnson may have even been in some ways worse than Purdue Pharma, as difficult as that could be.
And just to kind of finish off on what you just said, you are a public health doctor, right? And at this point, you are working on matters that are important to the public health of this country and the state of Oklahoma, right?
That's correct.
How important, if at all, is it that folks that do research and investigation and education on the public health, how important is it that you and others have access to the kind of documents that we're seeing in this case?
It's extremely important. for different reasons. I believe, like with litigation against big tobacco, there's a positive public health impact when we learn, for example, when we learned in that litigation about how big tobacco lied, when we learned about how they manipulated nicotine levels, when we learned about how they targeted adolescents, when we learned about how they lied about cancer risk and addiction.
I'm going to object. This is argument. He had no involvement in tobacco litigation. It's just argument. You can ask about our facts and our situation. This is just argument. I object.
I conclude that.
Thank you.
Let's tie it to this case. I understand the history there, but, and frankly, my firm is involved in that. But let's talk about the importance, if there's any at all, to getting the information out to people like you to do your work after this case is over.
Yes, so learning about how we were lied to, for the medical community to understand how it was deceived, I think will have an important public health impact. But it goes beyond that. I think that we may have more than 500,000 Americans who've lost their lives from the outset of this opioid crisis due to opioid-related overdoses. We know that millions of families across the United States have been affected. I do believe this is one of the worst, if not the worst, public health catastrophe we have ever faced as a nation. And I think that requires us to think about where we might have gone wrong. This was not a virus. When we talk about epidemics, we think about typically about viruses or disease outbreaks. This was not caused by a virus. This was a man-made epidemic. And so I think we need to, from this experience, think about what measures need to be put into place to prevent something like this from ever happening again. I think we need better firewalls so that there's less industry influence on continuing medical education. We need better medical journal policies so that journal articles that are influenced by pharmaceutical companies can have less of an impact. There are many different areas where we need to start learning what happened and come up with policies to prevent this, something like this from happening again. And I think the only way that happens is with a full airing of what went wrong. And again, it's why I'm very thankful to the court for making this trial public.
Okay, thank you. Now, you mentioned the word virus. You're familiar with something from that we've already got into evidence, States 4519. You've seen what we call the heat map of the spread of substance use admission in this country since 1999, right?
That's right. What we're looking at here, just to be clear, this is 3 years into the epidemic. The epidemic began in 1996. This is 3 years into the epidemic. This is data that comes from state-licensed drug and alcohol treatment programs that are required to ask people when they come in for treatment, what is the primary drug that you're addicted to? This is the rate of people who came into those treatment centers saying that the primary drug I'm addicted to is a prescription opioid. And what you can see is that 3 years into the epidemic, we had just a few states that were lighting up as red or maroon, showing that they had a very high rate of people coming in for treatment addicted to prescription opioids.
Well, let's look at that. But before we do, you've heard some comments about the documents we've looked at, that a lot of them have been national internal marketing strategies, right?
That's correct.
Have you seen, though, through this case and the evidence that we presented, that those strategies were deployed here in Oklahoma, for example, by the internet or through sales reps?
Yes. Well, yes. What happened in what was happening across the United States was happening in Oklahoma.
Let's carry that forward. The idea of what happened in the U.S. happened in Oklahoma. Here, in 1999, we see Oklahoma in this 15 to 18 category, which is kind of a mustard color, right?
That's correct.
Okay, so let's look at 2001. Now, what we see over here on the eastern side of the U.S., including part of Appalachia, is that many states have turned red into this 19 to 44 category, right?
That's correct.
So when you talk about a national effort that's coming here, this virus, as you called it, of opioid-related problems, is it moving westward?
It's hard to say that it's moving, but you definitely see in some regions the problem seems to be more severe than in other regions. And a pretty consistent finding is that the opioid addiction epidemic is worse in states and counties where you see more opioids prescribed. And if I could mention a study too that was published just, I think in January, what the researchers found by linking data sets. They linked a federal data set that shows payments to doctors from drug companies. It could be payments really for a dinner or a lunch or maybe some other type of payment. They linked that to a data set of doctors prescribing through, I think, the Medicare Part D program, and they linked it to death data from counties. And what they found was a striking relationship such that in counties where doctors took more money from drug companies that make opioids, those were counties where more opioids were prescribed and where more people died.
So let's touch on that idea of influence there. In your investigatory work, your training, your experience, all the qualifications you have on this issue, have you had an opportunity to look at whether doctors, when you inquire as to whether they believe they've been influenced by these marketing messages, can you tell the court whether or not those doctors stand up and say, oh yeah, they got me, or do they deny it?
Yeah, it's very interesting. If you ask a doctor whether or not they're influenced by a dinner at a conference paid for by a drug company where they hear a talk, or if you ask them whether or not they're influenced
Your Honor,
by...
I'm sorry, may we approach real quick?
Yes.
Dr. Klein, you were interrupted about halfway through your answer. We'll just kind of refresh here. You were, what I'd asked you, or what you were, let's just kind of reset the question. You don't have to start over here. Are you aware, based on your investigations, factual research, the fact that you're a psychiatrist, your medical training, all your frontline work on the opioid crisis, what do you know whether when you have experience personally with doctors, will they stand up readily and understand or know that they've been influenced by these marketing practices? Or is it more subtle?
I believe many doctors think that the marketing doesn't influence them. They think they can sit and have the free dinner and drink a glass of wine and listen to a talk, and that they may even believe that there's going to be some bias in the talk, but they generally think they can detect the bias, it won't influence them. They don't believe, there are many doctors who don't think that the drug reps who visit them are influencing them, but studies have shown that it does have an impact, and of course it has an impact. Why else would pharmaceutical companies spend so much money on sales reps and CMEs and sponsoring symposia at conferences if it didn't have an impact on prescribing?
Have you seen numerous documents in this trial, in this courtroom, where the word influence was used?
Yes.
Do you have an opinion, based upon all of your study, research, and understanding of this case, whether it is even appropriate for this defendant to say that when they use the word influence, what they really meant was just educate?
I believe they know that what they were doing was influencing prescribers, not educating prescribers.
Now let's look at 2001. We've seen evidence in this case that in the early 2000s, were Johnson & Johnson and Janssen aware that we were seeing an increase of abuse and addiction in the country?
By 2001?
Yes.
Yes, by 2001, there were very clear reports from the Northeast, from Appalachia, from Florida, that there were serious problems associated with the increase in prescribing, particularly of OxyContin.
Okay. Now, let's look at 2003. Oklahoma's changing colors, isn't it?
It is.
And you know, I have to correct myself. You and I have talked about this. I have a problem discerning different colors. I said we were in the mustard category, but we actually have moved up to a darker shade, right?
That's the mustard color. So this is mustard, red, maroon.
Okay. And mustard represents 15 to 18.
Yes.
Okay. So now let's go to 2005. All of a sudden, we're in a different color, right?
Yes.
And as this virus, as you called it, and I think Dr. Mazaludis did too, we see more red and this darkest crimson color coming more over the states, right?
That's right. And just something else to sort of keep your eye on as you go forward in time would be the range of 0 per 100,000 up to 214 people per 100,000. That 214 being in some of the states that are showing up as maroon, and even the range is increasing. So you'll see maroon is 45 or more. It started to be a lot more than 45.
So let's see what happens in 2007. Is it spreading further?
Yes, you see many states now have turned red, many states have turned maroon, and the range now, that would indicate that the state with the most serious problem has 340 people per 100,000 in the population showing up addicted to prescription opioids.
Now, 2007, is that around the same time that Johnson & Johnson was starting a new unbranded marketing strategy to say that undertreated pain's an epidemic and we need more opioids?
Yes, I believe that before they had the official approval of Nucynta, before they were legally allowed to market Nucynta, they had an unbranded campaign leading up to the rollout in which they encouraged opioid prescribing, despite the fact that we had a severe epidemic at this point. What you've seen now is a sharp increase in a disease over a short period of time. That is the definition of an epidemic.
Now, let's look at 2009. Wow, it's different, isn't it?
It is. basically the whole country has been affected.
And what color is Oklahoma?
Maroon, it's in the highest category, which now is a range up to 379 per 100,000.
Just hold that thought. Let's go back. See what it looked like in 1999, 10 years earlier. Look at that. Let me step back here. I want to see this with my own eyes. Doctor, what do you have to say about that? How did we look in 1999?
It was bad. If you could go back to 1996, we didn't have any problem. It was bad in 1999. There were states with a problem that was emerging, but had we responded appropriately, had opioid manufacturers, had Purdue Pharma and Johnson & Johnson said in 1990, I guess this is 2001, had they said in 2001, gee, there's a problem with the increase in prescribing, it's leading to adverse public health consequences, we should stop encouraging aggressive use, we should stop giving money to organizations that are promoting opioid use. Had they just pulled back when it was clear that we were experiencing a public health problem caused by opioids, I firmly believe the epidemic never would have gotten as bad as it did.
Okay, hang tight. We're going to go back and forth on a couple of things. So let's go back to where we were in 1999 nationally, and you see Oklahoma. You mentioned, could we go back to 96? Can you pull up our graph on opioid sales and death in Oklahoma, Mr. Medina? Okay, let's look at it in Oklahoma. 1996, before the sales started to increase, what was our rate per 100,000 in the population of prescription drug-related overdose deaths? It was less than what?
Before 1996, it looks like the rate was 1 person per 100,000.
Now, as we move forward, like we just saw in that heat map, what happens between 96 and 2009 where that map is?
The deaths go up.
In fact, in the 2009 range, is that the lowest or highest that we had in the state?
Highest.
Now, it's up to over 14 per 100,000, right?
Correct.
Can we go back to 2009 on the heat map, Mr. Medina?
And just to be clear, so what we were looking at with the rate of death and up to 14 per 100,000, deaths from a prescription opioid are literally the tip of an iceberg when you think about all the other consequences. So if you start with death at the tip and addiction at the bottom, there are many more people who are suffering with opioid addiction whose families have been affected. If you are a young person who's opioid addicted, this is going to have an impact on your parents and siblings. If you're an adult with opioid addiction, this is going to have an impact on your children. And as we know, this impacts communities. So the deaths are the tip of an iceberg. This is an addiction epidemic.
What happened nationally? You see 2009, go back to ours. It happened right here, right then, in this state.
That's correct.
Objection, Your Honor. He's leading the witness again. That's Harvey.
Objection sustained.
Doctor, is there any doubt? Can you state whether or not what happened nationally happened right here in this state?
There is no doubt in my mind.
Thank you. Please turn your seat. Thank you, Your Honor. Dr. Clodney, we're going to try to move forward through a few areas. One of the things I'd like to focus on real quick, are you familiar that pharmaceutical companies, including Johnson & Johnson and Janssen, would fund what were called journal articles?
Yes, I know that they work to have journal articles published. I believe in some cases, maybe they were supplements to a medical journal. In other cases, journal articles that they worked on appeared in a journal.
Your Honor, may I approach with State's Exhibit 0972?
Yes.
So I've just handed you State's 0972. Your Honor, this is a graph of tapentadol acute pain publications from Johnson & Johnson. We move to admit and publish at this time.
No objection, Your Honor.
States 972 will be admitted into the evidence.
Thank you, Your Honor. May we publish this?
Yes, you may.
Thank you. So, Dr. Kolodny, you've looked at this document before, have you not?
I have.
And I don't want to belabor the point and go over all of these, but Your Honor, may I approach?
Yes, you may.
Are these examples of different journal articles or publications that Janssen was reviewing as it was launching Ms. Dee Meshelman's the project she was working with on tapentadol?
I believe that these are journal articles that Johnson & Johnson wanted placed in journals as part of the rollout of tapentadol, or during the rollout of tapentadol. I believe these are articles that Johnson & Johnson wanted published because they believed these articles would improve sales of tapentadol.
Well, so let's look at that, because you're here to talk about what actually happened. So let's look at one of these. If we look here, we see acute publication number 3, and it says Charles Argoff. Is that somebody that was on our web map a minute ago?
Yes,
And did you go to Mr. Argoff's deposition in this case?
I did attend his deposition.
Thank you. So you know what he said.
I know what he said at his deposition, and I'm familiar with his work.
Not holding you to a memory test on a deposition. I know that happened a long time ago. You were there, right?
Yes.
Okay, so here we see that. What happened? Can you just walk the court through these bullet points about how this occurs?
So I think what we're looking at, I think this document is an action plan. And so on this, you're seeing on this plan what's happened previously, where things are currently, and what the next steps are. And for this paper with Dr. Argoff, you're seeing an indication that they had a conference call with him about his paper, that they sent an outline of the paper to him for him to review, that he approved the outline for the paper. There was a follow-up call with author, first draft sent to author. That suggests to me that Johnson & Johnson actually wrote the paper for Dr. Argoff. Then it says telephone call with author, May 5th, approved draft with minor comments. And then under current status, it says revised draft with alternative journal target sent to Dr. Argoff June 19th. And then next steps, editorial styling for journal.
So if we look at this one kind of in sum, the conference call was December 3rd, and we jump over here to current status in June. They're sending, they being Janssen, sending a revised draft to this KOL, right?
Objection, argumentative, and leading, Your Honor.
That's correct.
Overruled.
Let the judge-
Overruled. May answer the question, Dr. Kolodny.
That's correct.
Okay, thank you. Now let's turn to the next one. We'll just go through a couple more of these. If we could focus on this top one here. So here we see a chronic publication, long-term consequences of chronic pain. You see that one?
I do.
Now we have an author. Who is that?
Dr. Fine is a prominent key opinion leader. He was president of the American Academy of Pain Medicine at one point. And I believe he was on the board of directors for the American Pain Foundation as well.
The AAPM, the same one that did the consensus statement?
The same one, and if you had your spider web up, you'd probably see lots of lines connected to Perry Fine.
Okay. We won't put it back up. We'll just look over here. You don't need to read all these, but is it true, we see here there's a call in February, and then the author approved an outline with comments in May?
Yes.
But before that May 23rd outline, we see something different. What happens on May 21st?
outline sent to author.
Sent to the author.
That's correct. When pharmaceutical companies write journal articles that get published with a doctor's name on it, that's called ghostwriting. And this does appear, this document does suggest that Johnson & Johnson was engaged in ghostwriting journal articles that were published with key opinion leaders' names on them.
Let's turn to page 004. So if we can focus on the second one, chronic pain is a challenge to manage due to its complex pathophysiology. We look here, we see first draft developed,
We do.
and then under that it says Nithya and Kimberly provided comments on March 30th. You with me?
It does say that.
And then it goes down and says revised draft sent to Pricara April 20th, but at the bottom it says what?
KOL review at APS.
Now, Doc, are you suggesting that every time Janssen funded a study, the study was bad?
No, and these aren't even studies, I think. These are journal articles. But I don't believe that every research study that Johnson & Johnson funded was necessarily a bad study.
Okay. Well, let's go down to the next to last one, chronic ER message platform. It says here, development of message platforms and supportive references. You with me?
I am.
And it goes through a process, and at the bottom it says, what?
The bottom that says KOL review at APS.
APS, would that be the American Pain Society?
Yes, so that I believe would mean at the annual meeting of the American Pain Society.
Okay, thank you. So doctor, based upon your experience, your training, your background, your work in this field, do you have an opinion whether Janssen sought to use publications like these and others as a way to influence?
Yes, if this is in fact evidence that, if this does indicate that Johnson & Johnson was ghostwriting journal articles, that would be done to influence prescribers, and it's also unethical.
Now, Dr. Kolodny, you're also familiar with CMEs for continuing medical education,
That's correct.
and you've heard quite a bit of testimony about that in this case.
I have.
Your Honor, may I approach?
Yes, you may.
We move to admit States 2364, which is a November 2001 email and attachment from Janssen.
No objection.
States 2364 will be admitted into the evidence. You may publish.
Thank you very much, Your Honor. Dr. Kolodny, if we'll look to the first page here, you see an email to Katie Chupa, or K. Chupa, that's a name we've seen in this case,
Yes.
and it's dated what?
November 6, 2001.
Okay, and if we look at the subject line, it says implementing segmentation.
Yes.
Your Honor, may I approach the board?
You may.
Thank you. So, can you just read for the court here? We need to set this up to go into the document, but what does the first sentence say?
Attached, please find the revised deck with 2 slides added that provide the view based on Duragesic target physicians.
Target. Now, the date 2001, we just looked at that heat map. That was fairly early on in what we were starting to see of the spread of the virus, as you call it, right?
Not that early. By 2001, it was we had a serious problem in the U.S.
Okay. Let's turn to the first page here of the attachment. So right here when it says implementing segmentation, we see a word. What does it say?
Leveraging the Duragesic segmentation to maximize return on investment.
And let's turn to the next page, Mr. Medina. Let's just look at what they're talking about here. here it says there are 5 major components in the process to design and implement a segmentation in the field. And can you just go over here with the court what they're talking about under segment identification?
It says identify unique physician behavioral segments using advanced statistical techniques.
Okay. Now, have you been to CME?
I have.
And is it required to go to? Do you have to do a certain number of hours?
Generally, some states require a certain number of CME credits, and many professional organizations, or for maintaining your board certification, a certain number of CME credits are required.
Have you ever been to a CME where it was disclosed to you as an audience member that the purpose of the CME was to influence you and get a return on investment for the company funding?
No, I've never heard that disclosed at a CME event.
So if you were at such a thing and it wasn't disclosed to you, would you, you're a psychiatrist, you might not know that that was actually an intent behind the messaging.
Sorry?
I don't always ask the best questions. You're a psychiatrist.
I am.
And if you were in the audience at a CME that was intended to influence you,
Yes.
but nobody told you about it,
Yes.
just based on your psychiatric background, would it be obvious or easy to know that that was really the purpose of the CME?
Well, if it was me, I would I would know if it was a CME that was sponsored by a drug company. And they do disclose that. You do. They don't always make that prominent. Sometimes it's in the very fine print, and you have to go looking for it. But if I was at a CME event and I knew that Johnson & Johnson was paying for that CME event, because of my experience in research, I would believe that Johnson & Johnson is not just paying for this CME out of goodwill. They're paying for this CME because they're interested in seeing, because they believe it will have a benefit, a positive financial benefit to their company.
That's you after 15 plus years investigating these issues, right?
Correct.
Okay, so let's look at this document. What do they call it at the bottom?
Tactical implementation.
All right, and one of the things we see on assessment of attitudes, what are they estimating?
Identify attitudes that are behind the exhibited behavior. Estimate expected changes in physician prescribing by segment. It looks like they're trying to be able to measure the impact of changing attitudes.
So remember, I kept asking Ms. D. Meschel about influence, and she would say, educate.
Yes, I do recall that.
Okay, so let's look over here. Measuring what kind of response?
Promotion response.
And it says, what does it say here about educate? Let's look at the second bullet point.
Determine which medical education programs have the greatest return on investment by segment.
Return on investment?
That's correct. They're investing in education, which is to promote sales of products. That's why they do this.
Well, lest they say you're just making it up, let's look over at the second bullet point on allocating resources. Read those 2 bullet points for the court, please.
Determine the optimal allocation of details by segment. Identify the most profitable target segments for each type of medical education program.
Oh, wait a second. You went too fast. Educate or identify the most profitable targets?
Identify the most profitable targets.
All right, let's go to the next page. Why segment? Well, see the question they asked?
Yes.
So it says all physicians do not follow the average volume or share trend. Physicians respond differently to the same type of level of what?
Promotional activity.
Okay. The document about education, does it say they respond different to the same type of educational activity?
No, it says promotional activity.
Okay, and let's go down to how they're doing this. Different, what kind of tactics?
Promotional tactics.
Generate different what?
Return on investment.
Based on what?
Physician characteristics and behaviors.
Educate? Does it say it? Physicians may be prescribing or not prescribing your product for different reasons. You see that?
I do.
And what does it say at the bottom?
You mean the next bullet or
The last bullet.
Segmentation enables you to identify potential vulnerabilities to competitive activity.
Okay. Now, let's go to the next page. This is pretty interesting. It shows the overall total prescription dollar share trend. You see that?
I do.
And we've seen documents that internally Janssen was looking at the potential threat of the oxy abuse problem. Do you remember seeing those?
I do.
And we see here on this example, it says the total prescription share trend of Duragesic shows that after a period of decline, now we look at this period of decline, it's starting in late 99, and after December 2000, it starts to go back up, right?
Yes.
And that's what they say. Duragesic share is on the rise.
Yes.
Okay, and when they are doing this analysis, you talked to the court about IMS, you remember
Yes.
that? What's the data source here based on the physicians that they're looking at?
IMS, now IQVIA.
So they're able to look at their share based on IMS by looking at 319,397 physicians prescribing in what market?
The chronic pain market.
All right, now, Mr. Medina, let's go please to page 8 of that document, probably 09. So we see here about how to enhance segmentation targeting. It says additional data can be added to the shared trend segmentation to further enhance its value, right?
Yes.
And what kind of factors do they say are key?
Specialty identification, share trend segmentation, and the chronic pain market volume.
Okay, and it says identify key specialties for further promotion activity, and the top one is?
Primary care.
Now let's go over here to the other side. Well, actually, let's go to share trend segmentation. One of the things it says to do is to identify physicians that have similar prescribing patterns for Duragesic,
Yes.
but also to do what?
Identify the usage patterns of competitors.
Now, this idea about influencer educate, over here it says chronic pain market volume.
Yes, it does.
You read for the court, explain what's going on there.
Calculate annual prescribing levels for each physician in the chronic pain market. Higher volume physicians are given more importance.
So let's just look at an example of that. Can you go 2 pages forward? Okay, we see here something, Duragesic, Oxycontin segmentation overlap, targeted physicians, right?
Yes.
Okay, we see over here on the left on Oxycontin segments, we see it goes from very high share to 0 share, right?
It does.
And then on the, I guess that's the x-axis, it has Duragesic
Yes.
segments, correct?
Yes.
And they're, same thing, very high share to 0 share, right?
Yes.
And are they looking at the intersection or overlap?
Yes.
Now, you've been doing this a while. Were these companies, Janssen and Johnson Johnson, were they out in the field just blind to what doctors were doing, or did they have a lot of data to look at what their marketing activities were doing to prescribe?
Objection, argument.
Sustained, please rephrase.
You've been doing this a while, correct?
Mm-hmm. Yes.
You've been investigating this.
Yes.
You have experience and expertise in this issue.
I do.
You've looked at their marketing materials.
I do.
You've looked at their marketing messages. Correct?
Yes. Yes.
You're familiar with IMS data.
Yes.
You've looked at documents like this one.
I have.
So let me ask you a question.
Sure.
In your opinion, was Janssen, when it was doing this marketing and seeing if it would work, Were they operating blindly, or did they have access to data where they could look at the impact of messaging on prescribing?
Johnson & Johnson had a data-driven approach to gain as much as they could of the existing chronic pain market and to make that chronic pain market grow.
So let's carry that forward and go to page 11. Attitudinal assessment. The previous segmentation work provides insight into the patterns of what?
It says the previous segmentation work provides insight into the patterns of behavior, but does not provide the whys behind the behavior.
You're a psychiatrist. Part of what you do is to look at the whys?
Yes, that's true.
Okay, so we look down here and it's talking about primary market research is critical in assessing why physicians in each segment prescribe Duragesic. Right?
Yes.
So let's look at it. What does it say on the last two bullet points?
The research can be used to identify how prescribing may change by segment due to competitive activity or other market factors. Message development and testing can be conducted to determine which messages have the most impact for each segment. These messages can then be communicated to the sales team to be used in the field.
The sales team could be used in the field. Now, you've looked at call notes here in Oklahoma.
I have.
The sales team
Yes,
and the field was doctor's offices in this state.
that's correct.
Do you have a doctor's office?
Not at the moment. I have an office at a university right now.
Is that office on property?
Yes, it is.
Okay, thank you. Let's turn to the next page. So we look at assessing promotional activity. Let's just look at some of these bullet points. The two most frequently analyzed promotional activities are what?
Detailing and medical education.
Now, detailing, is that what you've heard referred to as a sales rep going to target a physician?
Yes, that's detailing.
Okay, so let's just go back to this. This is in this document that they have. Detailing is referred to as what type of activity?
It's referred to as a promotional activity.
Promotional, not education, right?
That's correct.
Okay. Evaluation of medical education programs by segment can provide P gains in share, duration of effect, interaction with details. You see those?
I do.
And what's the last one?
Return on investment.
Then if we go to the last bullet point, an assessment can be made to determine if coordinated promotional activity results in.
Improved return on investment.
Okay. Now let's go to the next page. I asked you if they have data. Let's look here at this. This is an analysis that's done. Again, it says the source is share from what?
IMS.
And it's PDEs, which is a primary detail, calculated from what?
Janssen detail file.
The analysis was done on called-on physicians from August 99 to July 2001, right?
That's what it says.
Just for the court's analysis, where it says PDE, that's an acronym. And can you read for the court what that actually means? Top line.
PDE stands for primary detailing equivalence.
All right, and that is where, when someone goes into the doctor's office, their primary focus is the drug they're selling, right?
I believe so.
Okay, so we won't get into this data, but you can see here that we've got an analysis of the number of average detail equivalents going along the x-axis, measuring change in dollar share points on the y-axis, right?
Yes. What this appears to show is that the more detailing, the more money that Johnson & Johnson made.
Okay, so let's look at the last two pages, allocating resources. So if we look at this, it says using this historical response analysis as a foundation, estimate the future response by physician segment. And it goes on to say what?
Leverage market research and other data sources to guide estimation.
And then, as part of this, you identify the level of detailing activity that with maximum
Return
what?
on investment,
Okay.
overall and within segment.
And then what does it say about medical education programs?
It says that they want to determine which medical education programs have the greatest return on investment.
And assess the impact of retargeting through an overlap analysis on old and new physician targets.
That's what it says.
Let's go to the last page. So here we see tactical implementation. What is the first bullet point?
Centralized targeting activities for medical education programs which leverage the developed segments and historical return on investment evaluations.
And then on medical education, we see them saying what? Provide what to who?
Provide representatives with direction on local program recruitment.
Thank you. Dr. Klodny, based on your experience, training, work in the field, do you believe that when Janssen was funding medical education, it was doing it simply to educate?
No, they very clearly were interested in increasing profits.
Okay. And you saw on the bottom of that document, there was a source there that was providing this information to Janssen, right?
It looked like much of this data was based on IMS data.
Well, in the document, we see that there was a group called Health Products Research that was providing this deck to them, correct?
Oh, yes.
And we've seen evidence as you've gone through this case, have you not, that Janssen would look to groups like McKinsey or other groups to provide them data and analysis to develop strategies?
Actually,
Have you seen that?
Leading an argument.
Sustained.
Can you state whether or not you have seen examples of groups like McKinsey or this one providing information to Janssen for which it would then consider its strategies?
Yes, I have seen reports from consultants like this one and McKinsey advising Johnson & Johnson on how to increase profits.
Mr. Beckworth, we're going to go ahead and stop here and take a break.
Perfect. Thank you so much, Aaron.
Let's resume at 10:30.
Thank you.
Thank you.
Thank you. So we'll try and do our best to stop right then.
I will abide by that instruction. May I approach?
Yes.
Thank you. States Exhibit 1710, Your Honor. Jansen Doctor would ask to permit and publish this.
Just 1 minute. No.
State 1710 will be admitted to the evidence and permission granted.
Dr. Kolodny, continuing on this professional education concept, you see States 1710 is titled Tapentadol Professional Education Message Platform.
I see that.
Okay, and Mr. Medina, there's a lot in here. We're just going to turn to the page here that says number 1, due to the limitations. Now, Dr. Kolodny, yesterday we were talking about, while they're getting that, we were talking about the use of studies such as Porter and Jick.
Yes.
That's not the right page here. There we go. Page 13. The use of studies like Porter and Jick. And so here we see in this education platform, the titles, due to the limitations of current analgesic therapy, many patients continue to suffer from undermanaged acute, moderate to severe pain. You see that title?
Yes, I do.
And just real quickly, if I may approach, Your Honor.
You may.
If we look at message or supporting statements, down here on the bottom left it says, there is a significant need for education of both physicians and patients about the appropriate use of opioid analgesics.
Correct.
Now, you saw a document that avoid the addiction ditch document, and you saw here in Oklahoma they were using this 2.6% number.
Yes.
We see here in this national education platform, what are they using?
2.6% for misuse and no evidence of iatrogenic addiction, de novo addiction.
Now, by 2006 or 7, was that an accurate statement?
No, it's not an accurate statement. And to rely on that particular study to communicate de novo risk of addiction, or that the risk of iatrogenic addiction is low, is not appropriate. That study that they're relying on was a Purdue Pharma study that Russell Portnoy based on data collected by Purdue Pharma. And this was not a study in which patients who were treated with opioids long-term were carefully assessed to see if any had become opioid addicted. There was an enormous dropout rate. This was a study that Purdue Pharma had to call off before it was even completed. And this was a study where the journal that actually published it had serious concerns, but did ultimately publish it. It is not a study that should ever be used by anyone to suggest a low risk of addiction.
So here we see next, if we go down to following chronic opioid analgesia therapy, de novo abuse addiction reported in only 0.19% of patients, and it cites Fishbane. What do you have to say about that?
That's also very deceptive. So Fishbane was not a study. What David Fishbane did in this paper was to combine data from studies. What his paper, you could call it a systematic review, not even a meta-analysis. A meta-analysis requires a higher degree of control. What Dr. Fishbane did was basically to collect papers that had been published that were mainly short-term clinical trials for drug approval. And if a particular study was published and you read the study and it mentioned that a patient had been exposed to opioids for 60 or 90 days, and there was just simply no mention in the study of whether or not anybody became addicted, they counted that as 0. Not one of the studies that were included in the Fishbane systematic review was actually designed to answer a question about what is the risk of iatrogenic addiction. Not one of the studies carefully evaluated people who had been exposed to opioids, either by even just talking to patients on the phone. They didn't even do that. And so to try to cite David Fishbane, that systematic review, to communicate a low risk of addiction is just as deceptive as citing the one-paragraph letter to the editor by Porter and Jeck.
Because we know from Jansen's own testimony here that even today they still don't know the real rate of iatrogenic addiction.
That's correct.
So if a patient walked into a doctor's office and said, and the doctor said, hey, I think we need to put you on long-term opioid. And the patient said, okay, doctor, I've heard about addiction, I'm worried about addiction. What is the percentage chance that I'm going to be addicted in a year and I have no family history?
Well, for one thing, many people use the term addiction and dependence interchangeably. And so what a doctor should tell every patient is that if you take an opioid around the clock every day for as little as 5 days, you are going to become physiologically dependent on the drug. You may, or you will likely feel uncomfortable when you discontinue the drug, and that the longer you take the drug and the higher the dose, the more difficult it will be for you to ever come off of the opioid. Physiological dependence is not necessarily identical to addiction, but it's closely related. With regard to developing addiction, the answer should be, I don't know what your chance of becoming opioid addicted is. There is no way to predict in advance, but this is a highly addictive drug, and evidence suggests that patients who take it long term, that more than 25% are likely to be addicted.
So should the doctor ever be told by a drug company that the rate is 2.6 or 0.19, or that Porter and Jig says less than 1%?
Absolutely not. This is a medication which, when people are repeatedly exposed to it, they can develop a life-threatening condition that can have a devastating impact on them and their family. No one should ever downplay the risk or minimize the risk or point to papers as evidence that are not evidence.
Which is exactly, well, let me ask this here. Can you state whether or not the concept you just gave about not downplaying the risk is what their own board told them in 2001 in State's Exhibit 0035?
I remember the minutes from that advisory board. I recall their advisory board telling them, or a presentation by Nat Katz that discussed a long history, human history, showing us that opioids are a double-edged sword, that they can cause death and addiction, I recall. And I also recall the board communicating to Johnson & Johnson that if the prescribing of Duragesic increased in the same way that OxyContin increased, that one could predict that there would be a similar increase in abuse. That's my recollection of the minutes.
Okay. May I approach, Your Honor?
Yes.
I have States 2372, which is a C&D that Jansen funded called Responsible Prescribing.
Yes.
We move to admit and publish this document.
No objection, Your Honor.
States 2372 will be admitted into the evidence, and you have permission to publish.
Thank you, Your Honor. May I approach?
Yes, you may.
Thank you. Now, Dr. Clodney, you're familiar with a book called Responsible Opioid Prescribing that Scott Fishman wrote and was put out by the Federation of State Medical Boards, right?
I am.
Okay, so if we'll turn, you just leave it like that, Mr. Dina. This is a slideshow from something, and it says here, this program is supported, or also supported by educational grants from King Pharmaceuticals Purdue Pharma, and Pricare J&J. See that?
That's what it says.
So we've got an educational program funded, supported by Johnson & Johnson and Purdue at the same time, right?
Yes.
Okay, so let's look at the learning objectives here on this. Turn at the bottom. Define addiction, pseudo-addiction, and dependence. Right?
Yes.
Now, we're going to talk about pseudo-addiction in a minute, but you've also testified quite a bit about documents that looked at addiction as a myth, right? Is that right?
Yes.
So what's the second learning objective here?
Articulate common myths about opioid therapy that can interfere with one's ability to manage pain effectively.
Okay, now back out, please. So one of the things we've heard a lot about here is barriers. That's a marketing message that Janssen's used, right?
Yes, barriers generally is used to communicate the need. Barrier generally means, barriers is basically reframing good reasons for being cautious with opioids as impediments to treating pain compassionately.
And so here, when we look at the overview that's being talked about, we see things like reducing pain, minimizing risk of diversion. But the second one is what?
Barriers to more effective pain management.
Okay, if you can back out. In this educational document, we go to the next page, please. When it talks about the scope of the problem, let's see here. A number is given for people suffering from chronic pain. What do they say?
They're saying 70 million.
And if we go down to the next slide, it talks about key terms. You pull it up. One of those terms is what?
Pseudo-addiction.
And it defines it as drug-seeking behavior in a patient who's not what?
Not consuming adequate doses of pain relief medication, meaning the patient is not getting a high enough dose of opioids so that they look like they're addicted. You should give them more. Once you achieve a proper dose, you'll see that the patient's function improves. That's the message here, and just absolutely awful that this would be communicated to prescribers in a program that was supposed to be educating them. The prescribers who receive this education would be, if they believe this, and I think many would be likely to harm their patients.
Okay, we're going to come back to this book in pseudo-addiction in just a moment. But let's look at some of the other messages that are in this Purdue and Johnson & Johnson simultaneously funded program. We go to the next page. Now, you remember we looked at documents where both the defendants here at Purdue were referring to the idea of a myth, addiction is a myth. Remember that?
Yes.
Okay, so let's look what they say here. First one, myths. This is the title of this section. Myth versus fact. Opioid medications are always addicting. And it then goes on. Let's go to this one. The bottom line. Myth. Opioid medications are always addicting. And doctor, what do they say is a fact?
Many studies show that opioids are rarely addicting when used properly for the management of chronic pain. That's a false statement.
Now, it doesn't say Duragesic, it says opioids, right?
That's correct.
And this document was funded simultaneously by J&J and who?
Purdue and King.
And we go over to States Exhibit 906, which we have a page from, and what's happening with oxycodone consumption in the United States of America after 1996?
The prescribing is taking off, and we're seeing parallel increases in addiction and overdose deaths going up along with the increase in prescribing.
And that one, 906, is about oxycodone.
I'm sorry?
That document, 906,
Yes.
is about oxycodone
Yes.
consumption.
Yes.
And that's Purdue.
I'm sorry?
Well, Purdue made OxyContin.
Yes.
Johnson & Johnson provided oxycodone to Purdue, correct?
Yes.
Okay. Let's go to the next slide. Bottom right, please. Here's one. Myth versus fact. Opioid doses inevitably rise over time because of physical tolerance. You see that one?
I do.
Now let's back out to the next page. On the top right, here's what they say. What is the fact they say?
Unless the underlying cause of pain gets worse, patients are likely to remain on the same dose or only need small increases over time. That's also, that's a misleading statement. I wouldn't say it's completely false. There are many patients who stay on the same dose. Not every patient has their doses escalate. But it's a misleading statement because it's suggesting that tolerance is not a problem with chronic opioid therapy when tolerance is a major problem with chronic opioid therapy.
Okay. Let's go to page 006. Here, if we can pull up pseudo-addiction versus addiction. And Doctor, we're going to come to the book here in a minute. I just want you to look at this. So in this educational, or so be it, or so it's called, presentation, this lists pseudo-addiction versus addiction, and it lists several things like clock watching, obtaining drugs from more than one physician, and hoarding opioids, right?
That's correct. The idea is that these are behaviors that look like addiction. For example, the patient's hoarding the pills or going to multiple doctors or watching the clock, waiting for their next dose. It looks like your patient has become addicted, but I believe what they're communicating there is that those are not behaviors that are addiction, those are pseudo-addiction.
Okay, now going back to the last thing we'll look at on this presentation, we see in the overview on the right-hand side of the front page, it references a book, Responsible Opioid Prescribing, right?
That's correct.
And I believe this book's in evidence. What is it? 1445? So I'm holding a full hard copy of the book, Responsible Opioid Prescribing 1445.
Yes.
Okay, thank you. Let's talk about this book. Mr. Medina, we have a page from the book, I think, we'd like to show.
Mr. Beckworth?
Yes, sir.
I know we admitted a portion of the book and then the entire book. I want to make sure we have the right court exhibit number.
Mr. Pate, I'm going to let him handle that if you don't mind, Your Honor.
States 1445 is the entire book.
Okay.
We don't have it as admitted at this point, Your Honor.
Yeah, I don't think we admitted it as that number.
If you'd like to-
I know that I admitted it, and I know that there was a portion of the book that was one number, and then there was the entire book. And it was my intention to admit the entire book as evidence, but not the second exhibit that was part of the book. So I want to get that straightened out.
That's exactly right, Your Honor, which is why we're showing states 1445, which is the entire book, which is what you admitted when we discussed admitting the excerpt that was part of the deposition. Instead, we admitted states 1445, and that's what this is.
Thank you, Mr. Pate.
We can get it cleared up. That's not a big deal.
If anybody wants the book, I'll give it. Would you like it, this version?
I have an 8.5 by 11 size
Okay, sure.
version. Thank you.
Okay, yes, sir. And from that, can we turn to 14450038? Your Honor, may I approach?
You may.
So this is an insert graph from the book. And if you look at table 2, Dr. Clogging, it says what?
It says at the top, behavioral indications of addiction and pseudo-addiction.
All right. So, Doctor, over here on the left side, it says behaviors less indicative of addiction.
That is what it says.
Okay. Can we go through these, please?
Yes, we can.
One of the ones it shows is it's less indicative of addiction if you hoard medications.
That's what it says.
Now, you're a psychiatrist who deals with this. Is it a good thing if you have a patient who comes in who's hoarding medications?
No, if a patient is hoarding a narcotic prescription, that is very concerning behavior that requires careful evaluation.
Now, here's another one. You might be less addicted if you're taking someone else's pain medications. As a psychiatrist, what do you think about that
So,
statement?
yeah, they're saying, don't, it's less likely to be addicted if you're borrowing other people's pain medication. And of course, if somebody is on opioid medication, they're receiving their own prescription, and they're also taking somebody else's opioid pain medication or borrowing it, that is a red flag that the patient may have addiction.
Now, let's look at the corollary. This document says that it's more indicative of addiction if you, rather than just take someone else's, you do what?
Try to get opioids from more than one source.
All right, let's look at Fuller. This table, when it's trying to talk about pseudo-addiction, it says it's less indicative of addiction if you, what?
Aggressively complain to doctor for more drugs, so that a patient who is on opioids, they're coming to your office, and they are aggressively saying, doctor, I need more and more opioids, that's less likely to be addiction. The patient who's doing that, that's more likely to be pseudo-addiction.
As a psychiatrist and a medical doctor who's trained in this field, what do you think about that?
That's a patient who's aggressively asking for more medication. That's a red flag for addiction.
Now, look at what they say. You know, that's pseudo-addiction, but over here is more indicative of addiction. What is the corollary or the converse to that?
Yeah, I don't know that these are corollaries. I think we've got a list of what's less likely to be addiction and a list of what's they say is more likely to be addiction. I don't know that they're necessarily related to each other. I think they're just listed.
Okay, so let's look at the other side.
Okay.
Number 4 on the other side. What might be more indicative of addiction? What do they say you have to have?
Performing sex for drugs. So what you're really seeing is that they're trying to describe behaviors that could be addiction as the most extreme, outrageous behaviors that you're least likely to come across. Of course, if a patient is correctly diagnosed as addiction, an opioid manufacturer has just lost a customer. And because of, we had discussed this previously, a law passed in 1914, the Harrison Act. If the patient is addicted and the doctor's continuing to give prescriptions to the patient who's addicted, that's illegal. If you know your patient is addicted to opioids and you keep prescribing for them, that's against the law. You're supposed to send that patient for addiction treatment. So if you characterize the most egregious behavior that you're least likely to see as addiction, and the more common behaviors that are red flags for addiction as pseudo-addiction, you can maintain your customer base.
So doctor, as a psychiatrist, medical doctor, trained in this field, do you have an opinion on whether we should be looking at people and saying you're really only an addict if you are buying pain medications from street dealers or trying to get opioids from more than one source or performing sex for drugs?
No, if anything, it should be the complete opposite. Even the slightest red flag, the slightest indication that your patient might have addiction, might have this life-threatening condition, the education for prescribers should be stop, take a deep breath, talk with family members of that patient and get collateral information, because the patient who's becoming addicted may not want you to know it because they're either ashamed or they're afraid you'll cut them off. So get all the information you can, carefully assess that patient for addiction. If you're not skilled at assessing that patient for addiction, refer that patient to someone who can assess them for addiction, because they may have developed this horrible disease from your treatment. That's what the message should be, not trying to communicate that you don't need to worry about addiction and give more opioids because it's pseudo-addiction if they have one of these behaviors on the left side of the table.
So for example, if someone is telling their doctor that they're expressing concern to their doctor or family members that their pain might lead to the use of street drugs, or they're requesting or using more opioids than recommended, should that tell the doctor that that's just pseudo-addiction and to prescribe more drugs?
Yeah, so if a patient is telling their doctor or telling their family members that if I don't get more opioids, I'm going to go buy drugs on the street, the idea that that could be pseudo-addiction, that it's not addiction, and that same patient who's saying they're going to go to the street should be given a higher dose, that's outrageous guidance. And this type of guidance, I firmly believe, led to a loss, has led to many deaths.
Well, let's explore this a little further. I mean, we look at what they're saying. As a psychiatrist, is it difficult for the ordinary, let me say it difficult, I don't want to be disrespectful to someone who's a doctor. If you're not a psychiatrist, if you're a family care or primary care physician,
Yes.
is addiction difficult to diagnose and treat, or can it be?
Addiction is very difficult to diagnose because, as I mentioned, a patient who's suffering from opioid addiction and knows that they're addicted is likely to be very ashamed. There's a stigma with the disease of addiction. So a patient who may have started off taking opioids as prescribed by a doctor, but now is craving them, may be taking extra doses, may start engaging in what is sometimes termed doctor shopping. They're going to feel very embarrassed by that, and they may not recognize that they've developed a disease caused by repeated exposure to a highly addictive drug. They may feel like, there's something wrong with me, and so the patient will be ashamed, and that's one reason it's difficult. The other reason it's very difficult to diagnose is once somebody becomes addicted, their life will revolve around maintaining their opioid supply to make sure that they don't run out. So that patient who's visiting a primary care doctor for the prescription will often do everything they possibly can to hide from that doctor that they're addicted. Whatever they need to say to the doctor to be able to walk out with the prescription, they'll say. If the doctor needs to hear that their pain is well controlled in order to get the prescription, they'll say my pain is well controlled. If they think the doctor needs to hear that their pain is getting worse, they'll say their pain is getting worse. The last thing they want to do is jeopardize access to a legitimate supply, because what will that mean? That might mean turning to the street or having to line up at a methadone maintenance clinic. Another reason that it can be difficult to diagnose is that a patient may be addicted and not know that they're addicted. You see that more with other drugs, like alcohol addiction. You're more likely to see people with severe alcohol addiction and not know it. But so for a variety of reasons, it's extremely difficult to detect addiction in patients on chronic opioid therapy. And this is the very last, it's not even, I can't even say it's the last thing we should be doing. We should never do anything like this.
Should we have been, well, not we, because folks that put this out, should they have been saying that, to not have pseudo-addiction, you need to see red flags like prostituting oneself for money to buy drugs, or even worse, engaging in human sex trafficking, prostituting others for drugs? Is that responsible opioid prescribing to tell people that kind of stuff?
It's pretty ridiculous. I mean, how many doctors are, even if their patient, their addiction progressed to the point that they prostituted somebody in order to get money to buy drugs, how would a doctor ever even know that? They're putting items on this list that a doctor would, it's very unlikely that a doctor would ever hear it from a patient, find it out. This is a way of maintaining customer base.
Now, we just looked at 2372. That was a responsible opioid prescribing educational event funded by this defendant and Purdue. And what book did they cite to talk about pseudo-addiction?
The cover of Responsible Opioid Prescribing is on one of the slides, and the messages in this CME that Johnson & Johnson paid for come from this book.
the book that's currently up there?
That's correct.
Okay. Now, doctor, you're familiar with speaker bureaus, right?
I am.
And have you had a chance to see in this case, we had an exhibit 30080. We're not going to go into detail about it now, but did Janssen pay quite many doctors in Oklahoma for meals and engagements?
Yes, many.
Okay. Let's talk about speaker bureaus. Can you tell the court just a little bit about what you understood those to be?
Well, a doctor who's going to be invited onto a drug company's speakers bureau will get paid to give talks. And there are, I believe, roughly two types of speakers that are on the speakers bureau. There are the true KOLs who are invited onto a speakers bureau because they can influence other clinicians and get prescribing to go up. And then there are the clinicians who are invited onto a speakers bureau almost as a kickback, as a way of incentivizing that doctor to prescribe more, to thank them for prescribing. I've seen some evidence from call notes that might suggest that Johnson & Johnson might have been moving in that direction. But we do know that this is something that drug companies have done. Insys, in part, was convicted criminally because they had a completely sham speakers bureau where if a doctor prescribed enough fentanyl spray, they were put on speakers bureaus.
Okay.
Jackson moved to strike that. He indicated that he saw no evidence other than something might have happened when he went into other companies. So I would move to strike the portion of the testimony about other companies, not Janssen, Johnson & Johnson.
Yeah, I think what he was referring to, what maybe I can just cure that. You have seen the volume of documents that this company produced showing payments made to doctors in Oklahoma to be speakers, go to meals, and things like that, right?
That's right, and I have seen some evidence that Johnson & Johnson might have engaged in that behavior, but not overwhelming evidence that I didn't see clear evidence that they were bribing doctors.
Okay,
Your
so
Honor, I would renew my motion to strike the portion of the testimony that followed about his observations of other companies.
may I respond to that?
Well, you respond, sure.
Yeah, just to clarify, I think we're conflating two issues. What you said was you didn't see clear evidence that this defendant was bribing doctors, correct?
That's correct.
Okay, so I think he's answered the question they're asking.
Well, I still would ask for the testimony
The testimony relating to your client?
that followed up about others.
Do you want the part in
About
or out?
INSYS?
Pardon?
About INSYS, the other company, is that what you're?
Yes.
I'll strike that testimony.
Do you want to strike the part where he said that he didn't know that they were bribing doctors?
No, Mr. Yoder was referring to the testimony by Dr. Cloudney about INSYS. I believe.
Just the INSYS part?
That's what I understand your objection to be.
Okay. Now,
Okay.
stepping short of bribing, have you seen the evidence that Janssen was paying doctors in Oklahoma for meals, lunches, promotional type things, and speaker engagements?
Objection asked and answered.
Overrule.
Yes, I did, and I also saw a call note where a doctor, where the sales rep wrote that the doctor wants to be on the speakers bureau, and it says, I told doctor he needs to prescribe more, I think it was Duragesic, and have more experience before we'll put you on the speakers bureau. I did see a call note like that.
Okay, thank you, doctor. Now, we're going to talk about call notes here in just a second. If I may approach with 1744, Your Honor?
Yes.
Thank you. We move to admit and publish this email.
No objection.
State's Exhibit 1774 will be admitted and permission granted.
Thank you very much, Your Honor. So on this document, we're looking at something from October 11, 2010, correct?
That's correct.
Now, if we can just go to page 002 for a second. May I approach, Your Honor?
Yes.
Thank you. So we're going to get into Bill's call notes here in just a minute. So we talked about IMS data, and we saw some data tracking earlier before we took a break.
Yes, we did.
So here you see in this email an example. It says attached is the weekly Nucynta hot sheet, and it's showing TRX data through September 24th, 2010.
Yes.
Okay, and right here, just kind of show the court, what does it say? Key takeaway.
Negative 1.7% total prescription decrease this week for the pain sales force, plus 0.8% total prescription increase for the AI/GI sales force. Pain sales force at 41% for on track for call activity, and AI/GI at 50% for on track for call activity.
So they're looking, correct me if I'm right here or not right, but they're looking at Salesforce and prescription tracking, right?
I believe that's what this is.
Okay, let's go to where it says Hot Shot Deep Dive. So here it says Hot Shot Deep Dive, and it's saying that this provides information included in the hot sheet, and one of the things is metrics that matter. You see that?
Yes.
It goes on to say the deep dive shows charts with more detailed and comprehensive metric for the nation and regions.
Yes.
And one of the things it says is total target universe by Salesforce.
Yes.
Okay. Down here at the bottom, what does it say? Additionally, what?
The hot sheet deep dive contains Nucynta total prescription performance by Salesforce by state.
So that goes back to the concepts we were looking at earlier. You understand, or do you understand whether the defendants were able to look at total prescriptions at the state level to see how or whether the Salesforce calls were corresponding to increased prescribing?
They had very accurate information on prescribing practices of doctors that that was purchased by IMS and sold to them.
Okay, doctor, let's go to the first page, the top of this email. In this report, something struck me. There's a mention of Oklahoma. You were here during the opening where the defendant was talking about our DUR board. Were you here?
Yes, I was.
Okay, so here it says DUR meetings this week. College of Pharmacy is recommending several opioids to go to Tier 3 as opposed to Tier 2, but the recommendation is that Nucynta stay at Tier 2 status quo. You see that?
Yes.
And it says, I am still working on eliminating or loosening that PA. Does that mean
Prior authorization.
with the state, but don't foresee that happening until ER comes out, right?
Yes.
Stay tuned for an update. I'll let you know how the meeting goes.
Yes.
And what state are we talking about?
Oklahoma.
So that's attached in the same document where we're talking about tracking sales data nationally on a state-by-state region.
Yes, and would it be helpful if I explained to the court what prior authorization is?
To the extent you know.
Yes, so prior authorization process is one in which an extra hurdle is put between a prescriber and a product. So for example, when a insurance company or a pharmacy benefit manager wants to prevent a doctor from prescribing a more expensive drug when there's a generic that's available, they may have a prior authorization where the doctor has to make a phone call to explain why they want the more expensive drug. A prior authorization will decrease prescribing and sales of a particular product. So what this would indicate is, where it says, I'm still working on eliminating or loosening that prior authorization with the state, but don't foresee that happening until ER comes out. It appears that there was an effort made to get rid of prior authorization.
Okay, and just to clarify for the court, we're talking about state level only at the Oklahoma DUR.
That's correct.
Okay, Your Honor, may I approach?
Yes, you may.
So, Dr. Plotney, you were here, and I don't know, you're always in the courtroom, but you've been monitoring the testimony online as well, right?
Yes, I have.
Were you here when I spent the better part of the day going over call notes with Johnson & Johnson?
Yes.
Okay, Your Honor, I'd like to publish a few of those, and we're not going to go extensively over those call notes, but what I'd like to ask you to do is when I show you one, if we can kind of have you explain to the court whether you see anything important in some of these call notes. So the first one, we close up the video. The first one we have, we've used these, but this was from page 232, line 391. So here's one that was a Holly Abraham sales rep. We've seen this before. Can you explain to the court whether you see any problems with the kind of messaging that's happening.
Yes, this is the call note I was just referring to, which sounds to me similar to what INSIS got into a lot of trouble for. Started telling me, and Holly Abraham is referring to what the doctor she detailed told her, started telling me that he wants to speak, I think that means for Jansen, told him that he is going to have to prescribe more Duragesic and more clinical experience with it.
Okay. And then it says, started telling me about Duragesic and abuse and nurses taking the old patches. And what does she say in response?
I said, how many more people do you think are abusing oral, that could be OxyContin, maybe was meant to be OC, oral BC, they are easier to get and get high from.
So do you see that as good or problematic?
This call note is very problematic because it looks like the doctor is being told if they prescribe more, then they can get money from the drug company to be on the speakers bureau. Basically, that's what it means. That's why this doctor wants to speak, and also the fact that concern is expressed about abuse and even nurses having a problem and using old patches. And the response there is that it's worse with some other drug.
Okay, so let's look at another example here. So this is one from Eric Thornhill in 2005. And here it says, asked Linda at the front desk to dispense the coupon and police the DAWs on each script. Now, remind the court, DAW means what?
Dispense as written. That's to make sure if a doctor doesn't write DAW on the prescription, a generic is likely to be filled.
And we've heard a lot of testimony about coupons and return on investment on those, right?
Yes, we did.
What does it say next about that?
Asked Linda at the
No, you've already read that.
she gets a Powerade Sonic when 5 coupons are gone.
And then follow up on the dinner with Dr. Wynn first on June.
Yes.
What do you have to say about that based on your experience, training, qualifications?
I'm not a lawyer, but I would wonder whether or not that's legal. That also sounds kind of like bribery. A front desk person at a doctor's office is going to be given something of value if when more coupons are given out that lead to more people using. And I think these were the coupons that said get your first 15 days free of Duragesic. So all of this is disturbing.
Your Honor, I object and I move to strike the testimony about speculating as to what might or might not be bribery. As Dr. Quaden said, he's not a lawyer. He has no expertise that would allow him to offer that opinion. If he wants to offer testimony about his reaction as a physician to these types of things, that's one thing. But going beyond that and suggesting that there's some type of illegality or unlawfulness, when he doesn't know anything more than what he's reading on the screen, it's not relevant. It's, I think, should be barred by 2403 as well. And I just don't think it's within the scope of any expertise he has and would be of any value to the court.
No, I respond.
Yes.
I believe Dr. Clyde was very clear in saying he's not a lawyer. He's not saying it's bribery. He said it sounded like getting something of benefit in exchange for prescribing. So I think we cleared it. I could ask for follow-up.
I'll move to strike the testimony referencing a possible commission of a crime.
Thank you.
Thank you.
Yeah, and Dr. Clyde, sure what the court said. Let's keep it in your wheelhouse, right?
Absolutely.
You're a doctor,
I am.
public health expert,
Yes.
scholar in the field of the opioid crisis.
Yes.
Just in your opinion as a medical doctor dealing with these issues, do you find it good or problematic to be offering folks something of value in return for giving out coupons to increase prescribing? Limited to that.
It is a problem, and we are talking about a highly addictive drug for which coupons are being given out for a patient to take this highly addictive drug for free. And this is all occurring in 2004. where we are already as a nation and Oklahoma facing in the midst of an epidemic of opioid addiction caused by overprescribing of opioids.
Okay, let's look at the next one. This is from 202, line 101. Okay, 422, 2004. This is from page 202, line 101. Here we've got a representative, and it says Duragesic asked him what he likes about C2 drugs, and he said they are addictive, right?
Ask him what he dislikes.
What he dislikes, and the doctor's saying they are addictive. You see that?
I do.
And the response is something we've seen in this court. I showed him the Don data and told him that was one of the benefits of Duragesic, the low abuse potential. I told him that when prescribing Duragesic, he doesn't have to worry about it when compared to other drugs. Doctor, as a medical professional trained in this field who's been involved in the front line of this opioid crisis, is a call note representation like that here in Oklahoma to win our doctor? Good or bad?
Very bad. So we know, and Johnson & Johnson knows, that fentanyl is a highly addictive drug. Johnson & Johnson's internal communications indicate they know it's a highly addictive drug. Fentanyl is classified by, in the Controlled Substances Act as a Schedule II drug, which means high potential for abuse and a high potential for development of addiction. So for a sales rep to tell a doctor who is appropriately concerned about addiction potential when prescribing opioids, to tell that doctor that there is a low abuse potential is totally inappropriate.
Let's look at, by the way, we talked about tramadol. You see here again, they're talking about Ultram in these sales visits as well, right?
Yes.
And it says what? Low abuse potential.
It does, and I think that's not, at that time, to say that Ultram had a low abuse potential wasn't, I can't say that that's inappropriate because it wasn't a scheduled drug at the time.
Now,
No, it was not a scheduled drug at the time.
we have seen, though, multiple examples of reps coming into Oklahoma doctors' offices using the spring break blitz for spraying and trains. Is that okay?
It's not okay, and actually I just misspoke. My understanding is that Johnson & Johnson was prohibited from touting Ultram as low abuse potential because it was given this unique status to be unscheduled. One of the caveats was that, yes, tramadol can be released as an unscheduled drug, but Johnson & Johnson can't promote it as low abuse potential or try and take advantage of the fact that it's unscheduled. So actually they were not supposed to tout tramadol as low abuse potential.
And the spring break blitz idea, we saw a whole bunch of examples of that. Shouldn't you be out advocating or marketing an opioid that way?
Absolutely not.
Okay. Now here's one. This is from April 1st, 2004, page 86, line 188. She said he finally had someone abuse Duragesic by eating it, ended up in hospital and almost died. Showed him Don data, and he agreed that it was rare people abuse it. Based on your experience and qualifications, is that kind of messaging appropriate?
No, and but also I think what we're seeing here is the impact of the deceptive use of the Dawn data. So if we went over a slide yesterday showing how the Dawn data was presented without a denominator, and how even there was manipulation of the percent increase to suggest there was a large percent increase with other drugs that had not occurred with Dawn. A busy doctor who may trust the sales rep and is glancing at that kind of data could easily come to the conclusion that yes, it must be rare. And so this case I heard about somebody abusing Duragesic must be an isolated event, because this looks like reliable data showing low rates of abuse.
just look at a couple. So, October 9, 2004, page 235, line 32. Spencer cooked breakfast, briefly spoke to Dr. C about Dr. D. Says here, they took more, I think that's vouchers, but I'm not sure they needed them. She said she had a patient waiting on the 12th. What does it say next? I need to what?
I need to push her to use more Duragesic. Her numbers are actually down since ad board. Hopefully they'll go up after Kessler talk.
Now, based on your training experience, is it okay or not okay for sales reps to be pushing doctors to use more of an opioid?
Not okay.
All right, let's look at just a couple more. Example here on page 80, line 103. Dawn data to put concern at ease. Based on your experience and qualifications, how do you feel about that? Good or bad?
Bad. We already know that this was deceptive. We saw it ourselves. Johnson & Johnson heard it from their medical advisory board. Don't use the Dawn data. And here we're seeing very clearly that Dawn data was used in exactly the way that it had been instructed not to use it.
Okay, let's do one more. So here's one from February 22nd, 2006. This is on page 489, line 1308. It says, had lunch with Larry, taking the doctor's name out. I talked about Ultram ER and went over dosing. It says this office sees more chronic lower back pain as opposed to OA. Is that osteoarthritis?
Yes.
We've seen many documents that Janssen was targeting chronic lower back pain, right?
Yes.
We need to find out what other types of chronic pain they see, and then what?
Target those patient types.
If anyone finds out soon, please let me know. Right?
Mm-hmm.
Will you speak up?
Yes.
As a doctor trained in this field and dealing with this opioid crisis, is this kind of messaging appropriate here in Oklahoma or anywhere?
No, it's not appropriate for sales reps to be trying to find out more about a doctor's patients. Sales reps do get lots of information about what a doctor prescribes. That's made available through what was IMS and now IQVIA, and that's legal. But sales reps are not supposed to be able to get or try to find out information about a doctor's patients.
So let's go, we'll do one more. July 17, 2003. This is page 439, line 408. Long lunch. Dinner with Lloyd set for July 24. You see here it says, seems a bit nervous about higher doses of Dur or Oxy, somewhat concerned about abuse. Need to share Dawn. You see that?
Yes, and I also see that it says long lunch and dinner. I don't know for certain, but this suggests that Johnson & Johnson paid for that long lunch and plans to pay for dinner for Lloyd on July 24th. And as we talked about previously, there's a study that shows that that type of payment for lunch and dinner influences prescribing, and that the opioid crisis is more severe where more prescribers take that lunch and dinner.
And it goes on to talk about showing the Simpson study and bringing the doctor's comfort level up for higher doses when necessary, right?
Yes, it does.
And then here it says, Lloyd coaching, want him to be more comfortable using Dur and dosing it higher.
Yes.
Doctor, based on your experience and qualifications, is that type of messaging here in Oklahoma okay?
No, it's not okay, and I believe that Johnson & Johnson heard that it's not okay from the FDA when they received a warning letter for using these studies.
Thank you, doctor. Now, you wrote a paper with Dr. Courtright at some point. Is that true?
That is true.
In that paper, can you give the court a very short overview of what it was or is?
It's a review article, an overview of the opioid addiction epidemic, and it was written at a time when I think many people still thought about the opioid addiction epidemic as a drug abuse problem rather than an epidemic of opioid addiction that had been caused by destroying the dam of narcotic conservatism and this increase in prescribing. And so the purpose of the paper was to provide an overview of the epidemic, to frame it the correct way, and to review strategies for preventing people from becoming opioid addicted, identifying opioid addicted people earlier, and increasing access to treatment and reducing harm.
Okay, Dr. Klodny, Your Honor, may I approach?
Yes, you may.
I have states 3138, which is a copy of Dr. Klodny's paper with Dr. Courtwright. I'd like to put that in evidence and publish it.
Your Honor, it's something I suppose he can rely on. It is hearsay. We're getting his testimony. I'm sure it's appropriate to be submitting this as well.
Your Honor, it's this witness's statement that he's adopting in court. It's widely published.
States 31, 38 will be admitted into the evidence and permission granted.
Thank you, Your Honor. And we'll go over this just briefly. It's a long report. May I approach?
Yes.
Now, Dr. Klodny, this study and paper with Dr. Courtwright, we'll just turn to page 0003. We've seen this graph here a lot in this case. You use this to show the increase in opioid sales, deaths, and treatment admissions from 99 to 2010, right?
That's correct.
Why did you look at that graph? Why is that important to you?
It's important because it's showing the relationship between the increase in prescribing and the parallel increases in addiction and overdose deaths. This is important because it would help a reader understand why we have an opioid addiction epidemic.
And is it your belief, or do you have a belief, that with the supply of opioid prescription drugs increasing in the United States, we had an increase in death and treatment admissions?
It's a fact that as prescribing went up, rates of addiction and overdose deaths increased in parallel.
Okay, we'll turn to 0007, please. Now, you have some charts under the heading opioid addiction is a key driver of morbidity and mortality.
That's right.
Can you explain to the court what these age group charts are and why they are important in your testimony?
Yes, so at the time that we wrote this paper, many, as I mentioned, the issue was frequently framed as a problem of abuse, recreational drug use, taking drugs to enjoy the effect. And because it was framed that way, the message was that we don't really need to reduce prescribing, we have to stop kids from getting into grandma's medicine chest. When in reality, what was fueling the epidemic was over-prescribing. It was the fact that every grandma now had opioids in her medicine chest. And although there was a focus, with good reason, on trying to prevent non-medical use of opioids by young people, very important because young people can easily become opioid addicted, really the mortality that we were experiencing was disproportionately impacting patients, older people, people likely to be prescribed opioids aggressively for chronic pain. What you see in the graph on the left is data from the National Survey on Drug Use and Health, and it's showing you past month non-medical use of opioids. And what you can see is that the age group where you would most likely find someone who took pain medicine in the past month, possibly to enjoy the effect, or experimenting with it or using it recreationally, not surprisingly, it's young people, 15 to 24, that are most likely to misuse or abuse a pill. But when you look at where the mortality was, which is the graph on the right in green, you'll see that the age group where we were experiencing the most prescription opioid overdose deaths were the age groups where prescription opioids were most aggressively prescribed. So on this chart, you'll see that it's middle-aged people, 45 to 54 years old, that were most likely to die from an opioid overdose, and that young people 15 to 24 actually had a significantly lower death rate. One other point I just want to make. When you look at the 65 and up category, it would appear that we see very few prescription opioid deaths in seniors. I don't believe that's the case. I believe that the data that we're reporting on is accurate, but as Claire Wynn testified, when an older person overdoses or dies from a prescription opioid overdose, let's say that individual doesn't wake up in the morning because they died of an overdose from a fentanyl patch or from OxyContin. In the morning when that individual is discovered, and it could be the spouse recognizing that their loved one is in bed next to them, deceased, what will typically happen is that 911 is called, EMS will arrive. If the person is cold and in rigor mortis, EMS leaves because they need to save people. And what will happen is that detectives typically come in most municipalities, and the detective is required to make a determination about whether or not that death is suspicious for a homicide, a suicide, or a drug overdose, a poisoning death. They have to determine whether it was an unnatural death, like I've just described, or potentially a death from natural causes, like the patient's medical problem. If a detective arrives to a scene and there's a young person, possibly with drug paraphernalia at the scene, that it's very clear to a detective that that's suspicious for a drug overdose. The body will make its way to the medical examiner. Toxicology is performed, and we'll know whether or not there was a prescription opioid overdose. When a senior doesn't wake up, and there's nothing suspicious at the scene, and it was a senior who had multiple medical problems, what will typically happen is the detective will contact that patient's doctor, and doctor, Mrs. Jones didn't wake up this morning. Do you have a possible cause of death? And the doctor may say, well, Mrs. Jones had coronary artery disease, hypertension, and so I believe she died of a natural cause, a heart attack. And that's what will go on to the death certificate. And even in a situation where everybody may have known that Mrs. Jones had a problem with her prescription opioids, the family knew she had a problem, maybe the doctor even knew it, nobody wants the patient to go to the medical examiner. They want the patient's body to go to the funeral parlor. Nobody wants their loved one to have died of a drug overdose. So very frequently, these deaths go uncounted. So I think actually that 65 and up category is potentially much higher than it appears.
Okay, thank you very much. Now let's just go up to the graph right above it. I just noticed I wanted to ask you. So here you have a chart of first-time non-medical use of pain relievers, and we see this going up from 0 to 3,000 and thousands on the y-axis, right?
Yes.
On the x-axis, we see dates, 91, 93, 95, and then we see like the 95, 96 time frame.
That's correct.
What happens to that first-time users after 1995? Does that number stay flat or does it go up?
No. So first-time non-medical use, and again, this is largely young people who were experimenting with prescription opioids. From basically 1995 till around 2001, there was an enormous increase in young people being exposed to opioids. Probably many of those young people would ultimately become opioid addicted. Then what you start to see is a decrease since 2002 in non-medical use of opioids. Again, young people who may be borrowing or experimenting with pills that they're getting from a friend or a family member for free. So you start to see a decline since 2002 in this non-medical use by mostly teenagers, yet our opioid addiction epidemic continued to get worse. Deaths were going up despite the decrease in non-medical use, again suggesting that the driver behind the opioid crisis was not kids experimenting with drugs, it was the medical community unfortunately prescribing too aggressively.
Well, and let's talk about that aggression. What happened in the 1996 timeframe? The APS and AAGM put out what?
A consensus statement calling for greater opioid use. That is, so you do see a very close relationship between the sharp increase in prescribing and the sharp increase in non-medical use. We started at this point in time overexposing the United States population to this highly addictive class of drug, and that's why you see this very sharp increase.
And in the course of this trial, have you looked at many pages of documents that said that Janssen's was looking to increase and influence prescribing?
Yes.
Okay, now looking at this chart, just this one is, we see a lot of charts, we've seen a lot where it just goes up after 95, whatever it is, right?
Yes.
Now, we know, don't we, from yesterday, that on this timeline, in 1994, is it true that Tasmanian alkaloids started developing the Norman poppy in anticipation of the growth of oxycodone? Have you seen that document?
I have seen that document.
Okay. Now, we also know, because we had Janssen's witness on the stand, that in 1997, Janssen started taking Duragesic and marketing it for something other than cancer pain, right?
That's correct. That's when they relaunched it for chronic pain.
Okay, one last thing that just struck me. It says over the past decade, white women ages 55 to 64 have also experienced the largest increase in accidental opioid overdose deaths. You see that?
Yes, and this is especially true in Oklahoma.
Well, let's look at that. Pull up one of the charts we've already, I think, seen in this case. This is one that Claire went over. What happened to females in Oklahoma between the ages of 40 and 64 as opioid sales increased?
Females had the largest increase in the rate of opioid overdose deaths, and by 2013 had not just, it wasn't just the largest increase or the sharpest increase, but also a higher death rate among middle-aged women than among men. And that's somewhat unique to Oklahoma. What happened nationally is we saw a sharper increase in women from opioid pain reliever overdose deaths than we saw in men. The increase was greater, but overall, still, there were more deaths in men than in women. But in Oklahoma, it wasn't just a sharper increase, it was also total numbers or rate of overdose death in middle-aged women was higher than men. This is not something you see in every state.
Hold on one second, doctor. It just flipped me a question in my mind, but we're going to look at an exhibit that's already in evidence here. Mr. Pate is my trusty exhibit guru. Can you pull up State's Exhibit 2375, Mr. Medina? Now, oh man. We talked about hooks. You remember that?
Yes, it's an appropriate term.
I wore my hook tie, I think yesterday.
Yeah.
Remember? Now I asked Mrs. Kimberly D. Meshlin about media hooks, and I asked her, how do you get a fish? And she said, with a hook. Remember that?
Yes, I do.
Okay. What does 2375-0010 say about their media opportunities at this company?
At the bottom, it says, News Hook, Gender Differences Study in Journal of Pain.
Mainstream media pitch, women are feeling the pain. Study says what every woman needs to know. Right?
Yes.
Thanks, Doctor. Doctor, we mentioned, or I think I asked you a question. You said the other day, I asked you if it was a right statistic that approximately 4 in 5 folks who are on illicit heroin, if there are studies that suggest they started on a prescription opioid. Have you heard of that study?
Yes, the statistic 4 out of 5 heroin users started with prescription opioids is commonly known. That statistic comes from a federal government paper. I think it is important to remind the court that in Oklahoma we do have, fortunately, far fewer people who've switched from prescription opioids to heroin. That switching has been a much more serious problem in other states. We do here in Oklahoma, fortunately, have less heroin use, but that statistic is widely accepted.
And you've also used the term several times that some studies or some folks will remark that the rate of addiction, iatrogenic addiction or substance use disorder using prescription opioids is as high as 1 in 4, 24%.
Yes, 1 in 4, 25%. That statistic comes from studies of the prevalence of opioid use disorder in patients who are on opioids long term. That 25% comes from a study, I think, that used DSM-4 criteria. Depending on the criteria you use, it can be even higher, up to 40% using DSM-5 criteria. But yes, that 25% or 1 in 4 is widely accepted by the scientific and medical community.
Okay, now doctor, is it true that you believe that to abate this crisis that we need to engage in new education and also extensive treatment?
Yes, I think we need counter-detailing education. We need to work as hard to get appropriate messages to prescribers as Johnson & Johnson did, disseminating misinformation to prescribers.
Okay, so we've just talked about a type of abatement effort, a percentage of substance use disorder as high as 25%, and the rate of first-time heroin users being about 80% coming off prescription drugs, right?
Yes.
So is there anyone that you've followed or reviewed that you could say agrees with those 3 statements?
There is someone by name I can mention who would agree with that. That
Who?
would be Dr. Timothy Fong.
Okay, so hold on. May I approach you?
Yes.
So I'm going to write that name over here. What court exhibit are we on, Mr. Payton?
Next one would be 59.
So that's the court, 59. So Tim Fong.
Yes.
Dr. Clyden,
Yes.
please tell the court who Tim Fong is.
Tim Fong is Johnson & Johnson's disclosed expert on this case. Tim Fong is an addiction psychiatrist at UCLA.
Tim Fong. J&J expert. Did I write that down right?
Yes, you did, and that is correct.
Now, Dr. Fong produced a disclosure and CV in this case, right?
He did.
And on it, he listed some presentations and speeches that he gave.
That's correct. His CV listed talks that he's given.
And you have had a chance to review that, have you not?
I did.
Do you believe it would be helpful to your testimony here in court to show some slides and some of the presentation that Dr. Fong gave that were listed on the disclosures that Janssen has provided in this case?
Yes, I believe it would be helpful.
Your Honor, may I approach?
Yes, you may.
Your Honor, may we approach briefly?
Yes, you may.